Awesome. So thanks for being my one-person lecture audience for inherited diseases affecting the retina and the rest of the body. We talked the other day about, how to memorize things, and I'll just reiterate a few things here, which is that, grouping things together and comparing and contrasting, figuring out how they're similar or different, really linking those individual factoids in your brain really helps you retain things. Also, repetition with increasing intervals, and also figuring out the reasons, the whys behind things are all really helpful strategies. So I divided up the diseases that affect the retina and the rest of the body into a couple different categories based on how the retina looks. So I'll just kind of go through, the photos of those. So this first category is things that look either like retinitis pigmentosa or like a cone rod dystrophy, like a bullseye maculopathy. That's one, that's kind of actually the largest group, of inherited diseases that affect the retina and the rest of the body. The other group that I categorize things into is things that cause macular problems, like here a cherry red spot or vascular tortuosity. They're kind of like findings in the posterior pole that are different from a dystrophy. Also, there's a category for fundus hypopigmentation. Another one for myopia and retinal detachment. And finally, one for peripheral non-perfusion, as you see here. So I'll just show you that overview slide again. So these are like the 5 different, retinal, this is what the retina looks like. Then we're kind of gonna, split them up further. I think there's a lot of different ways to group them together, and, probably the more different ways you can associate things, the better you'll remember them. So the first that we're going to cover is the things that look like retinitis pigmentosa or Leber's congenital amaurosis or cone rod dystrophy. So that, peripheral, bone spicules, constricted fields, or a bullseye, type of maculopathy. So I have some gross generalizations that apply to almost all the diseases in this group. Most of them are recessive. The reasons for that I think of as being many of them are mutations in enzymes. And for enzymes, like where one enzyme might catalyze 10,000 reactions, if you have half of the quantity of enzyme, that's usually enough to get the job done. So you really have to have no enzyme at all by, having 2 bad copies of the enzyme to have a disease. Another reason why, explanation I give myself for why these diseases are recessive is that a lot of times they're really bad. Like they're not only causing, blindness at a young age, but also major things in the rest of the body. So therefore, people that have it are, not likely to reproduce. So therefore, the gene only gets passed on in, a carrier person. If these, mutations were autosomal dominant, then it wouldn't really get passed down. Nobody would have it and reproduce. So I mentioned these diseases being really bad. Most of them, the vast majority of them, have neurological problems, which can vary from degeneration and death, where you had like a normal kid who stops walking, stops talking, and dies, or milder things like developmental delay. The way I categorize all the things that look like RP and bullseye is by the organelles, of the body that are infected. So this is my little drawing of a rod. So this might be kind of not intuitive, but what do you think I'm trying to indicate by this red?
Yeah, those are like the, shoot, I know that, like, I know rosin cones are different in that the fact that they have like those like discs that are either,
these are the outer segments. So the outer segment of the rods and cones are actually a modified primary cilium. So the cilia is the organ type I'm trying to indicate. So mutations that affect cilia affect the retina because of this importance to the outer segment in rods and cones as being a cilia. So the next 2 are also organelles within the cell that break things down. What do you think I'm trying to illustrate here?
I think peroxisomes and lysosomes.
Excellent. That's what I am trying to draw here. And then how about these little guys with the stripes in them? What do you think of
mitochondria?
Yeah, exactly. So rods and cones, they require a lot of energy. So those mitochondria, anything that affects the mitochondria is likely to affect them because they're just sucking up, tons of oxygen. They're also producing a lot of waste products, and that's where the lysosomes and peroxisomes come into play. So there's one extra category which isn't, part of a rod or cone, and it's not an organelle. Here I'm just illustrating a VLDL particle, so one of the little fat things that, when you absorb fats, they like get into your liver and they're chylomicrons, and then, all these other things. So that's what I'm trying to illustrate here. So these are the different subcategories of things that look like RP and cone rod. So, and I'll just go back to the picture just so that we know what we're, have a visual for what we're talking about here. And so first we'll talk about the ciliopathies. There's a synonym for ciliopathies, which is the renal retinal disorders. There's a couple of different renal phenotypes that occur. One is polycystic kidney disease, and the other one is nephronotysis. I don't know how to pronounce it, but it has the word tysis in it. It just means scarring and fibrosis and shriveling up of those kidneys. So what are some ciliopathies?
I know that, I think last time I was like, June is one of them, maybe?
Yeah, June. Yeah, that's one of the most rare and least commonly tested. So great job. If they have that, you'll be all over it. So the other types, the most common and the most likely to be tested is Bardet beetle. And here's the names of some other types. So they're distinguished based on like what their, unique clinical phenotypes outside of the eye are. Bardet beetle is, do you remember what the typical clinical picture is for that disease?
I know that they're obese.
Excellent.
And they also have polydactyly. And the reason why is because it's because I think Cole came up with this. It's like you picture a fat beetle with lots of legs. So obesity with polydactyly.
Oh, I like that.
Bardet beetle.
Okay, great.
Yeah. So that's what I now picture.
Yeah. Okay. So senior loken is characterized by the fact that only the kidneys and the retina are affected, nothing else.
Okay.
Joubert is characterized by the cerebellum that has these like weird shapes that looks like a molar tooth. And they also have eye colobomas. Alstrom is characterized by cardiomyopathy and hearing defects, and Meckel by encephalocele. June by thoracic dystrophy, which prevents them from breathing too well. Okay, great job. So what is the next organ that we're gonna cover?
I think, is it
what is another organ? Okay.
Yeah, lysosomes.
Oh, great. Wow, you have a good memory.
Oh, wow.
So, and what do lysosomes do?
I know that they just, in general, are the organelle that destroy waste products, or they're kind of like waste storage / breakdown sites?
Great. So yeah, they're waste breakdown sites. They degrade things. What are some types of lysosomal storage disorders? I guess I left this Batten disease on here. So we know that that's a lysosomal. Yeah. What is the other name for Batten's disease?
Oh, shoot. Batten disease. Oh, it's, is it something neuromuscular or something?
Yeah, so it does have the word neuronal in it, because it, obviously the horrible thing about Batten's disease is the neurodegeneration. So that's good. We'll stick with that, and I'll show you the rest together with the other diseases. So what are some other lysosomal storage diseases that can cause a picture like
I'm actually, is refsum peroxisomal?
Correct.
Okay, then I don't.
Very good. Well, excellent.
Yeah.
So the other words for Batten disease in there are ceroid lipofuscinosis. So in Batten disease, there's these like oxidized lipids that build up. So the way I remember ceroid is that cer means waxy, and it's in the word cerumen, which is earwax. And then lipofuscin, as you know, is what builds up in the retina, like in AMD, and causes, autofluorescence. The other things that can build up are heparin sulfate glycosaminoglycans in the mucopolysaccharidoses, Hurler, Hunter, Shea, and Sanfilippo. Just as a reminder what glycosaminoglycans are, they're these incredibly long chains of sugars, and this is just like a repeating unit that's in there. Alpha mannosidosis is another lysosomal storage disease that's really similar to the mucopolysaccharidoses, and glycoproteins are what get built up in the lysosomes. They build up because they don't get degraded. And then cystinosis is another lysosomal storage disorder. In that case, cysteine is what's building up. So what's the inheritance of most of these diseases?
Oh, I think, sorry, it was a loud sound. I think autosomal recessive.
Great. Is there one exception here to the?
Yeah, I think it's Hunter is X.
Great. Excellent. So we always want to remember which ones are X, because then they're going to come up on the test. Okay. So great. So in these some of these diseases, they have other problems in the eye. For the mucopolysaccharidoses and for alpha mannosidosis, you can think of them being kind of together because they're having sugar breakdown problems. What other eye problems do they have?
Does Batten disease have like a optic neuropathy? Is that? I'm
not sure, but I think a lot of these diseases that cause retinitis pigmentosa do cause optic nerve pallor.
Yeah, that's true. Like optic atrophy.
If they're causing, but I'm specifically asking about the mucopolysaccharidoses. Like what other chapter, what other book of the BCSE do you come across these mucopolysaccharidoses? In one of the books, there's an equivalent chapter to retina and systemic disease.
Oh, it's cornea.
Yeah, cornea and systemic disease, and that has another like crazy table, right? And
yeah.
These diseases all cause corneal clouding. How about cystinosis? What does that cause in the eye?
I cannot recall.
That's okay. Well, a good guess would be that it also affects the cornea. So,
okay.
And yes, it does cause corneal crystals actually that are treated with cysteamine drops. So this is just like a good way to like link the optic atrophy is there. So good job there.
Thanks.
But that's a good way to kind of link, the two chapters. And then cystinosis can also cause retinal crystals as well.
Gotcha.
What kind of systemic problems are characteristic of Batten disease?
Batten disease, developmental delay.
Yeah, so they kind of start off with, some milder symptoms of, having trouble, but then they really go downhill pretty quickly and usually, die within a couple of years. There's just progressive like weakness, and then they had learned words and then they've like lost them. It's really, really sad. So that's for the Batten disease. Mucopolysaccharidoses, they have more milder like developmental delay. They also have coarse facies and hepatosplenomegaly. I think of all those like carbohydrates, people like inject fillers, right, that are made of like hyaluronic acid, which is the glycosaminoglycan, like to puff things up. So I think that they just have like fillers everywhere, and that's why they have, coarse facies. They've got those in their liver too, just that those glycosaminoglycans building up, in the connective tissues. For cystinosis, this is like highly testable in that it has type 2 renal tubular acidosis or Fanconi syndrome, which is characterized by low potassium and phosphate. Also dwarfism, because of that low phosphate, they get rickets. And also in cystinosis, it's different from most of the other diseases that we'll talk about in that they're not having any neurodegeneration. I feel like there was like multiple opto questions that were on this, or maybe it just came up every time, and every time I didn't know it. So, because it's like I can hardly remember what the different types of renal tubular acidosis are anyway.
Yeah.
But okay. So then another thing I thought, this is like kind of a sidetrack, but I always am getting confused between homocystinuria and cystinosis. So what do we talk about is the phenotype of, cystinosis in the retina. What does it look like?
RP, like retinal degeneration.
Exactly. What else can happen in the retina with cystinosis?
Cystinosis.
What happens in the anterior segment in cystinosis?
Corneal crystal. Oh yeah, it was like crystals. So cornea and retina.
Exactly. Great. And then what do we just talk about with cystinosis and the rest of the body?
Yeah, so that would be the type 2 renal tubular acidosis.
Yes, you got it.
Yes.
Wonderful.
Maybe dwarfism, but no neurodegeneration.
Okay, wonderful. So so you'll just have to, I don't know, you could revisit that like in 30 minutes from now, and then like 4 hours from now, and then like, 2 days from now, and then maybe you'll remember it. I don't know. I probably won't. Okay. So the homocystinuria, what does that cause in the anterior segment?
Anterior segment, we always think about like it's displacement of, or it's like lens dislocation, like zonular weakness. And
exactly.
If it's superotemporal, or I think it's infranasal displacement.
I can't remember.
It's like one of them is like up and one of them is down.
I know, I know what you're talking about, but I can't recall. So, but yeah, that is a frequently tested thing. And then how about the rest of the body? What's the key thing that they want to ask you for when you take these people to cataract surgery?
Yes.
Aware of?
Right. I think that they are hypercoagulable is like the main thing. Otherwise they have like kind of Marfan-like features, but they have developmental delay. Okay,
great. Wonderful. And in the retina, they look more like a bullseye type of thing rather than a retinitis pigmentosa. Oh, I just have a little thing about the pathogenesis here, that the cystithione beta synthase enzyme converts homocysteine to methionine, but that's mutated in this case. Okay, so let's go on to the next organ, peroxisomes. So what do peroxisomes do?
I always forget, but I think, is it also, they also break down waste products?
Yes, great. So they also break down waste products. They specifically break down lipids, whereas lysosomes break down a whole bunch of different things. Mm-hmm. And then one question I had is, what do they mean by biogenesis? That's not a word that we commonly use. And so by peroxisome biogenesis, they mean that these mutations cause problems with peroxisomes forming or proteins getting into the peroxisome. So therefore, like everything that the peroxisome is degrading kind of builds up. So you mentioned Refsum disease. That's great that you remembered that that was a peroxisomal disorder. What are some other peroxisomal disorders?
I know, I just remember there's like one paragraph on there's like, is there a familial one also?
Yeah, so all of these are inherited. And actually, these three are really closely related. Like they used to call them separate diseases, but they all just call them the Zellweger spectrum now. Okay. But you still have to remember all three names. But there's Zellweger disease, neonatal adrenal leukodystrophy, infantile Refsum disease. And it's just in order of like when they die. Like the Zellweger people die really shortly after birth. Infantile Refsum disease, I think they like die in childhood, and the other ones like in between. Right. So they're characterized by really bad neurodegeneration. There's a couple, which is why you have this name, adrenal leukodystrophy. Leuko meaning the white matter of the brain is kind of having a dystrophy, just like the retina is having, RP and retinal dystrophy. So there's a couple other organs that are found to be affected in Zellweger disease. And they're captured in the name, the other name of Zellweger disease, which is cerebrohepatorenal.
Okay.
So we talked about the brain being affected, but also the liver and the kidney. And then they have increased phytanic acid in the blood, and the BCSC, I think, went back and forth and now saying that these people should not take as much phytanic acid. They should try to restrict their intake through foods and stuff.
Yeah, it looks like I just looked it up right now. It says dietary restriction of phytanic acid precursors may slow or stabilize the neuropathy, but typically do not affect the retinal degeneration.
Yeah. So thanks for sharing that. And then there's adult Refsum disease, which is actually separate from infantile Refsum disease. It's not as bad because instead of affecting the whole peroxisome, it's only affecting like one of the enzymes in there. And in that one, there's a special systemic finding that's associated. That's ichthyosis, or like scaliness, of the skin. So yeah, those are two separate diseases. Infantile is part of Zellweger and adult is separate, and their systemic findings are different. So next, let's talk about mitochondria. Mitochondria provide energy, or ATP. So what are some, I guess, systemic findings that are characteristic of mitochondrial disorders?
Yeah, I always think of like, they usually have, I guess, like coarse facies. Is that what I'm thinking of? No?
I'm not sure, if they have that.
Like
How
ragged.
about other eye findings other than a retinitis pigmentosa type picture?
I'm not sure.
It's okay. So I guess if one example of a disease is Kern-Sayre, what kind of other eye findings other than retinal degeneration do you see in Kern-Sayre?
Right. Is that the one? That's the one with like CPEO also. So you have like, a lot of restricted like motility and stuff like that.
And really bad ptosis. So they have, that characteristic, like they can't move their eyes at all, and then their eyelids are like, blocking their vision. So neurodegeneration, like we talked about, for all of these diseases, it's common in the mitochondrial disorders as well. And then hearing loss is a particularly characteristic problem for the mitochondrial disorders. In addition to Kern-Sayre, there's like a bunch of different abbreviations, most of which start with M and describe, with M being for mitochondrial and or maternally inherited, because mitochondria, you get all your mitochondria from your mom, in contrast to like your chromosomes. And most of these kind of spell out what the systemic problems are. For Kern-Sayre, what's the main systemic finding that they want you to be aware of because it could kill someone?
It's cardiomyopathy.
Yes, and they get a heart block.
Oh, heart block, right.
Yeah. And then do you remember what any of these abbreviations stand for?
I know for MELAS, because I've seen a few patients with it, it's a lactic acidosis.
Great. And what is,
encephalopathy?
I don't remember actually, but what is the S? How about the S? What is
it? Syndrome? It can't be syndrome.
Okay, it's okay. It's
stroke.
Yeah, look, you're right about the encephalopathy. So mitochondrial encephalopathy, lactic acidosis, and stroke. That's crazy that you've seen multiple people with that. That's really cool.
Maybe like two, multiple meaning like
more
I've
seen zero. That's multiple. And the way I think of it is that, the reason they're getting lactic acidosis is their, mitochondria aren't working very well. So instead of doing aerobic respiration, they're doing anaerobic respiration, going all the way back to, biochemistry. And then MRF stands for myoclonic epilepsy and ragged red fibers. I think of there as being not enough ATP for the muscles. NARP, neurogenic muscle weakness, ataxia, and RP. And then mid, maternally inherited diabetes and deafness. So those are the various things.
Is there a reason why, I guess you would think that if it's a lysosome, I guess you kind of touch on this with like the lysosomal diseases where sometimes it's not just the lysosome itself, like the whole organelle, it's like the enzymes. But it's just interesting that they have so many manifestations in one organelle. Like you'd think that mitochondria are used everywhere.
Yeah,
Why
right.
why is it specifically the like lactic acidosis and stroke versus like more of like ragged red fibers and muscles and
Right, exactly. It is really interesting. And I don't have any answers, but maybe some people have some good theories. Renee made us, my co-resident made us do a journal club on mitochondrial disorders.
oh
But
great.
I would say I didn't necessarily, I didn't remember anything in there that like made a lot of sense in
Yeah,
terms of why they're different, but
right.
it'll be great to know and helpful to remember.
Yeah.
Okay, so we covered the different organelles. Can you just remind me which organelles we've covered already?
Yes, we've covered the like ciliopathies or the cilia
Yeah,
with outer
yeah,
segments. And then we've covered the peroxisomes and then the
yeah.
lysosomes and then the mitochondria.
Okay,
We
and
have
then
not
so I think
VLDL.
those are all the organelles, and then there was the VLDL. So do you know what disease like affects the?
No.
It's okay. It's
No, no.
it's A beta lipoproteinemia.
Oh, okay, yeah.
So it's kind of like, by the rest, like our enzymes that affect, like carbohydrates and the, organelles. But in this disease, ApoB, so, we've heard of like ApoE and stuff. It's one of those proteins that make up the VLDL. And therefore, since their VLDLs are bad, they're not absorbing fats, and they have foul smelling stools. They get neurodegeneration. And then in these patients, it's important for them to supplement with vitamins A and E, which are fat soluble.
Mm-hmm. Right.
Okay, so we covered all those organelles and the LDL. So what are I think this is the end of the retinitis pigmentosa, phenotype. What are the other phenotypes that we're going to cover?
So we also have one of them is like maculopathies or like
Yeah,
macular
exactly.
red spot or like things
Yeah,
like that.
yeah.
We also have, oh shoot.
Yeah, so there's also, oh yeah, here was the overview of, so we just covered the retinal degenerations that look like RP or bullseye. Here are the different, organelles that we covered. And then, so here are all the different phenotypes. So yes, we covered this, RP and cone rod, and then we're going to cover macular problems and vessel tortuosity. The other phenotypes are fundus hypopigmentation, myopia and retinal detachment, and peripheral non-perfusion.
Sweet.
So we're going to cover the macular problems and vessel tortuosity next. Neither of these are pictures of these rare diseases, which I have never seen. So these are pictures of a CRAO, CRBO, but anyway. So again, there's some gross generalizations that they're recessive and they have neurological problems. This is really similar to, the first generalizations that we made about the things that look like RP, but the retinal phenotype is different. And again, I subcategorize them by like what their, biochemical problem is. And one, there are, again, lysosomal storage disorders that can cause this phenotype. And there's a second category, which is trinucleotide repeat disorders. So lysosomal storage disorders can cause, RP-like phenotype, or they can cause, these macular problems. And I think that was, at least for me, a source of confusion. I was always mixing up like, oh, does like Hurler, look like RP, or does that cause, red spot? So definitely keeping these straight is important. And these are the sphingolipidosis as opposed to the mucopolysaccharidoses, which cause, RP. Fucosidosis is another thing that looks like sphingolipidoses. So talking about these sphingolipidoses and fucosidosis, So the sphingolipids, they are important in myelin, and they do have like sugar residues that can be attached to these long, there's two like fatty acid chains. So their involvement in myelin helps to explain, why they're important for the brain functioning. And ganglio also helps tell us, okay, that's important for the, nerves. And fucosidosis, it's another sugar, but not one of these sphingolipidoses. So in general, they all have, neurodegeneration. For cherry red spots, there's two diseases, Tay-Sachs and Gaucher. Tay-Sachs is pretty bad in terms of, having that neurodegeneration in childhood, but Gaucher they live to adulthood, and they have these white spots. And then there's another sphingolipidosis that causes a macular halo. You remember? And then there's some others that cause retinal vessel tortuosity.
I thought, is it Niemann-Pick, the macular halo one?
Yep, excellent.
Does that also cause a cherry red spot though sometimes?
I have seen it written both ways. I don't know. I feel like the BCSE, when I looked at it, said the macular halo. And I guess I could see those two things being kind of similar, some sort of,
oh yeah,
reddish,
okay.
And then surrounded by whitish in the macula. So, but anyway, given that BCSE split them up like this, that's the way I did it. And then how about retinal vessel tortuosity?
I'm actually not sure. Is that Fabry's?
Yes, great job.
Yay!
Great job. So Fabry disease is another sphingolipidosis that its other name you should remember. It's called angiokeratoma corpus diffusum. Just remember, angio, because the problem in Fabry's is that these things are building up in the smooth muscle cells. So it builds up in the smooth muscle cells of the retina and causes tortuosity there, and it builds up in this, blood vessels of the skin, causing these little red bumps, angiokeratomas. And then Fabry disease also causes verticillata, and it's one of those X-linked diseases that we got to remember the inheritance for because it's different from the rest. And fucosidosis looks a lot like Fabry disease, but it's recessive. What's the inheritance of like Tay-Sachs?
Are they all autosomal recessive?
Excellent, very good. Yeah, all these lysosomal storage disorders are recessive because they're enzymes that would break these things down. All right. So other than lysosomal storage disorders, there is another subcategory of the things that can cause macular problems or vessel tortuosity, and that's trinucleotide repeat disorders. So what's the inheritance of, or I guess can you think of like non-eye relevant trinucleotide repeat disorder? Like the most famous one that you might have studied in medical school?
I cannot recall it right now.
I'm drawing a blank too, but it's where, you have like Huntington's disease.
Oh, yes. And you have like a thin corpus callosum or something. And
yeah, so in Huntington's disease, like the number, you have these like, CAGs or whatever they are that expand, as they're passed down. And like the more CAGs, like the younger you're going to get when you get the symptoms of Huntington's disease. So how is that inherited? Is that recessive or dominant?
That is dominant. Honestly, I'm dominant.
Correct. Yeah, because the effect, of having such a long, chain of whatever is happening there, is you only need one copy to have that negative effect.
Gotcha. So
the two trinucleotide repeat disorders that affect the retina are myotonic dystrophy and spinocerebellar ataxia 7. So do you know like what other things myotonic dystrophy can cause, either like in the eyes or the rest of the body?
Yeah, they definitely, well, they obviously have like a myopathy systemically, but I think that they also have like Christmas tree cataracts, right?
Great, wonderful.
And
Yeah.
then I remember when we were supposed to email you the like systemic things, I also, oh, I like that picture. It's a Christmas tree. Wait, are those like Handmaid's Tale Christmas trees?
This is Melania Trump. This is the White House Christmas
Wait,
decoration.
it's so fun.
I
Yeah,
know. I think. Wait, were there? Did they? Wait a minute. I feel like this is modified.
yeah, I think
After
it's a, I think
they
it's a
didn't.
Handmaid's
I did
Tale.
not notice that it had these little hats on there. This is hilarious. I just like pulled it really quickly and I like thought it was some sort of decoration, but now I realize it's been photoshopped to be Handmaid's Tale.
I was like, oh, how interesting. Yeah, Christmas tree cataracts. And then I think that I had also looked up when we were supposed to email you the systemic things that, like as a side note, Duchenne's muscular dystrophy doesn't have any like retina findings, but it has like an electronegative ERG or something, just like as a
Yeah.
random that I
Yeah,
memorized.
that's good to throw in there. I like didn't include that in this thing because I was like, I'm already including way too many things in this whole thing. But yeah. And then so the myotonic dystrophy, they also get chronic progressive external ophthalmoplegia.
Okay.
So what are the other diseases that we just talked about that also have CPEO?
Yeah, Kern-Sayers.
Yeah, exactly. And Kern-Sayre is caused by
Mitochondria.
excellent, great. And Kern-Sayre causes what kind of retinal phenotypes?
It causes, oh no, hold on. Is that an RP like?
Yeah, we've only covered two phenotypes. We're currently on the macular realms, so it's an RP. It's okay. It's like so overwhelming. There are so many these diseases. There's just too many of them. But so just like Kern-Sayre or myotonic dystrophy, people can have heart block. And there's some sort of medical term for this, but when they grab things, they can't let go. I couldn't remember the medical term for that, but
yeah, it's like a tonic or grip or something.
Yeah. And then so they can get like a pattern dystrophy. And then spinocerebellar atrophy, it's not spinocerebellar ataxia 7. Like thankfully we don't need to know about the other 6 or however many there are. Can cause like a macular dystrophy type of picture and neurodegeneration. Okay. So on to some other phenotypes. We're going to cover next fundus hypopigmentation. So what do you think this person has?
I mean, they have a very blonde fundus. Is it choroideremia?
Yeah, I guess, maybe it could be choroideremia, but I guess maybe think about what other causes of blonde fundus are there that affect the rest of the body.
Oh, albinism.
Yes, great, wonderful. Yeah. So this is a picture of someone with albinism. And there's a couple other diseases that are like associated with albinism that have more effects on the rest of the body. And then there's a couple other diseases that can cause fundus hypopigmentation. So as far as albinism goes, you can get it just in the eye. You can get the eye and the skin. And then these are the two diseases, Chidiac-Higashi and Hermansky-Pudlak, that have significant other findings in the body, not just hypopigmented skin.
Right. Those
then,
have platelet disorders, right? But then Hermansky-Pudlak has more like a Puerto Rican descent. But you said that maybe that's not clinically as relevant, but
yeah, definitely can be on the test. So Chidiac-Higashi, both of them can have bleeding issues, but Chidiac-Higashi has more of a susceptibility to infections. And in Hermansky-Pudlak, the platelet problems and bleeding problems are more prominent. There's another thing in Hermansky-Pudlak that starts with P that you might want to remember. It's pulmonary fibrosis.
Oh yeah, pulmonary fibrosis.
And then they have colitis, which doesn't start with a P. But anyway, what are you going to do? Okay, and then I guess let's talk about the inheritance. What's the inheritance of ocular versus oculocutaneous albinism?
Are they both autosomal recessive?
So they are both recessive, but
Oh,
one of them is,
X-linked?
yeah, and I
I
can't
don't.
remember. We'll have to click the next. We'll have to click the next thing to see. Okay,
Okay.
ocular is X-linked, and then
Okay.
oculocutaneous is autosomal recessive.
Okay.
We should come up with a way to remember that. Maybe it's because, like, I guess if you're oculocutaneous, you are gonna be more likely to get skin cancer and get made fun of and have a hard time. So maybe like that would
Yeah.
be more autosomal recessive, whereas like an X-linked thing can be, passed down because only the males are gonna be affected, but the females can pass it on. So
Yeah, like, I guess we don't see a lot of people with actually, well, sometimes I mean in peds we see people with oculocutaneous because they're like super fair and very blonde, but not like somebody that you like think of a stereotypical albinist, like like they're not like actually like that fair skinned. They're just usually like a blonde and blue-eyed kid. But you can kind of think of that, like you would think there would be more people, I guess, with that phenotype if it was more obvious.
yeah, we'll have to come up with a good way to
Yeah.
remember the ocular being X-linked and the oculocutaneous being recessive. And then, so in oculocutaneous, there's a mutation in tyrosinase, which makes melanin from tyrosine. So that might be on a test. And then there's Alagille and Waardenburg, which are both dominant. So tell me about Alagille, because I feel like this is a common source of inpatient consults.
Yeah, Alagille, is that one with posterior embryotoxin?
Yes, very good. And
Yeah, so
what kind of patients do they consult you to look for posterior embryotoxin on?
either Alagille or
But why are they looking for Alagille? Like what are they in the hospital for?
I know that Alagille usually has really bad like liver issues, liver problems.
Yes, yeah. Usually these people are like jaundiced and stuff. That's they're trying to figure out, okay, why do they have the jaundice? Then they ask you. I don't know. Have you ever seen posterior embryotoxin on these jaundice look for it consults?
No, I've never seen it in a consult, but I have seen posterior embryotoxin in just like EUAs on kids that we were like, oh, that's weird. Like I don't know if we ever noticed posterior embryotoxin and but yeah, you can actually see it like without a slit lamp. You'll just see like a more like
yeah.
Yeah.
So I feel like I did a bajillion of these consults, like look for posterior embryotoxin in these jaundice people. I only saw it once. I was really excited, but they already knew the person had Alagille syndrome, so I'm not sure why they're asking me to look.
Is that from birth? Is that congenital? Like how old was the kid?
They were young enough. They were a couple of years old, I think.
Okay, it wasn't like sometimes we get consulted on like neonates and really really young babies. Just wondering if it takes time to form or not, or something that
yeah, I don't know when the liver failure, like what the variability is in age of onset. I've definitely been consulted on like a 20-year-old or something. So, but who knows? That doesn't mean that the liver failure from Alagille can actually develop it at those ages. Okay. So yeah, and then Waardenburg syndrome. Do you remember anything about Waardenburg syndrome?
No, I don't.
Yeah, so that has like a white forelock and iris heterochromia. So basically, all of the things I think of are like from irregular pigmentation. So they have like that. They also have irregular pigmentation like in the retina, at Waardenburg, where part of their choroid is just more hypopigmented and the rest is more pigmented. I guess I've seen that. I don't know. Should I be looking? Some people just have that. Should I be looking for Waardenburg syndrome though? I don't know. But and then for Alagille, the whole fundus is hypopigmented. And then the other eye findings of albinism, I think you're probably familiar with: foveal hypoplasia, nystagmus, decreased visual acuity, translation defects of the iris, and an asymmetric VEP. Okay, so that's fundus hypopigmentation. What other phenotypes do you think we need to cover?
So we also have peripheral non-perfusion and then
Yep.
myopia and RDs.
Great, wonderful. So we're going to cover myopia
It's
and
interesting
RD.
with
Yep.
Alagille, like I don't think that I knew that I had a hypopigmented fundus. I think that
Yeah,
just
I didn't know that either.
yeah, whenever you see it, it's like it's grouped more into like the anterior segment dysgenesis stuff. So let's
Yeah, but then I looked at that like horrible table that's at the beginning of the chapter. And I was like, what's Alagille syndrome doing on here? So I
yeah.
like went through every one of those items on that horrible table. So I kept the ones that I felt like were relevant. Like I feel like, I don't know. Yeah, whoever came up with that table, maybe it was done a long time ago. Some of those diseases that are listed on there like are not like names of diseases that are currently in use. I think there was like olivopontocerebellar atrophy, but that's not anyway. So yeah, this is my version of
Oh
that
yeah,
table.
yeah.
Because I think that was like, I can't remember what was wrong with that. It was like maybe that disease is the same as spinocerebellar ataxia 7.
Gotcha.
Or some other disease, but yeah.
Yeah, and they
I
also
was,
have stuff in this table like Wardenberg that I'm pretty sure isn't really explicitly mentioned in the chapter.
oh yeah, no, they have many things there that are not
Yeah.
mentioned in the chapter, and there are many things in the text of the chapter that are not in the table.
Right.
It's like really unhelpful. But anyway, okay.
Okay.
So myopia and RD. So let's see. So these are generally, in contrast to many of the other disorders, they're dominant because they're caused by mutations in structural proteins. So for unlike enzymes, you know, if you have a protein that's supposed to make up the structure of the eye and there's half as much as you need, it's not enough, it's going to cause a problem.
Mhm.
So what are some diseases that are inherited that cause myopia and retinal detachment?
Yeah, so there's like well there's like is pathologic myopia one? Or not really. It's
Pathologic myopia is, you know, inherited, but we don't really like know
yeah,
which, you know,
like a
genes
single
most of the
loci.
time. And then
Yeah,
also there's not like systemic findings associated with it.
right. There's sticklers,
Yep, Stickler syndrome.
and then
Very
there's
good.
retinoschisis is one.
Yeah, I guess that does cause retinal detachment. Does it cause myopia?
No.
Okay. Okay. So the others that I had thought of here were Wagner, Noblock. I don't know how to pronounce that.
Oh, no block.
Yeah.
Yeah.
Marfan and Weil Marchesani. So like Stickler, Wagner, and Noblock are thought of as like the vitreoretinopathies or the hyaloidal. I don't know. There's some sort of word that starts with the word hyaloidal vitreopathies or something. And then there's the Marfan and Weil Marchesani, which, you know, we think of mostly as causing what in the anterior segment?
Oh, well, Marfan like ectopia lentis?
Yes, exactly. So Marfan and Weil Marchesani both cause ectopia lentis, but things that we don't think about as much is that they also cause myopia and a higher risk of retinal detachment.
Gotcha. Oh, it's the hereditary hyaloidoretinopathies.
Thank
And
you.
they also use this term that I didn't really understand because I saw it on opto questions, but it's like an optically empty vitreous. Is that just
Yeah,
that the
let's talk about that. Yeah, we're going to talk about that with pictures, the optically empty issue. So what genes are mutated in any of these conditions?
I do not. Oh, wait, no, wait, hold on. Sticklers is like collagen.
Yes, very good, very good. Excellent.
Something. It's collagen.
Very good. Yeah, that's great. So Stickler is caused by mutation in collagen, which is a major structural protein in the vitreous. Any other?
I don't know any of the other ones.
Okay, so Wagner is caused by mutations in Versican, the gene for which is VCAN, which is another structural protein that's the vitreoretinal interface. No block is collagen type 18. I think that's also at the vitreoretinal interface. And then Marfan syndrome and Weill-Marchesani can both be caused by mutations in FBN1, which encodes fibrillin. If you think of like fibrillin, it's actually making up the zonules, so fibrils, the zonules, and so that's why they get the ectopia lentis, because the protein that's making up the zonules is messed up. And then addressing Weill-Marchesani can be autosomal dominant or autosomal recessive caused by mutations in another gene. So we talked about the optically empty vitreous, which is sometimes used to refer to Stickler syndrome and sometimes used to refer to Wagner syndrome, although the appearance of the vitreous is different in both. So in Stickler syndrome, they have actually vitreous that you can see right behind the lens, and there's fibers in there that are much big. Normally in kids, their vitreous is really clear, and then in old people, there's fibers that you can see at the slit lamp. But in Stickler, you can see fibers even when they're kids, and then there's kind of like a membrane behind that, and then behind that membrane, you don't see any more vitreous. So I guess you could use the word optically empty to refer to this space in the back where you don't see any vitreous. Whereas in Wagner, the whole vitreous looks optically empty. The thing about Wagner that's also different is in Stickler, other than like having a myopic looking fundus and radial lattice, their fundus is pretty normal. Wagner syndrome patients, develop something that looks like a RP.
Oh, okay.
And in no block syndrome, they have a fibrillar vitreous and a cryptless iris. Those are the characteristic things there. And then as far as their systemic findings, what can you say about any of these diseases?
Yeah, the only one I really know is that Sticklers, they have a lot of them can be born with Pierrot band sequence.
Exactly.
And, yeah, because whenever a kid is born with that in the NICU, then Dr. Hoffman sees them on ROP rounds. And in the beginning, I was like, I don't understand. But that's what's helped me remember that they have that association.
Right. Yes. Always those things that you get inpatient consulted on repeatedly for, when you don't find anything. That's what helps you remember these rare conditions.
Yeah.
So yeah, in Stickler syndrome, they get the Pierrot-Bond sequence, which is like cleft palate, and then maybe the
micrognathia, and then
retrognathia. I remember.
Yeah, retrognathia and then micrognathia. I think that's what also helped me remember that is because the reason why a lot of these kids are in the NICU is not necessarily because they were premature, but because they actually need a trach because they have this small jaw and formed airway.
Yes, exactly. Great. And then they also get arthritis because that type 2 collagen that is in the vitreous is also in the cartilage. In Wagner syndrome, they don't have any systemic findings, so maybe I shouldn't even have been including it here in this lecture, but it seems like the right place. And then in no block syndrome, they can get encephalocele. Marfan syndrome, I think you should know about from medical school. I really can't remember everything, but they're tall.
Yeah.
And there's something about their aorta.
Yeah, and they have flexible joints and stuff. They have that thing where they can reach their thumb across or whatever.
Yeah, and then Weill-Marchesani people are short. All right, so we're doing really good. We just have one more phenotype to cover, peripheral non-perfusion. Hang in there.
Isn't this a picture of that guy's dad with fever?
Yeah.
Yes!
Yeah, I've been recycling pictures. So yeah, there's peripheral non-perfusion here. And you made the diagnosis correctly. This person does not have any systemic abnormalities. All right. So what are some inherited things that affect the rest of the body that can cause non-perfusion? I guess we talked about fever. Can the rest of the body be affected in fever?
I guess not.
Usually it's not.
Yeah.
But if they have one particular mutation, they can get osteoporosis.
Okay.
Oh, I just want to give some sort of aside that most of this I don't think will be on the test, but this stuff is stuff that Dr. Hartnett will ask you about if you're rotating with her. Oh,
Okay.
so it's good timing for you.
Yes, very good timing. Actually,
maybe she's already asked you these questions and you already know the answer.
We saw a kid actually that we were concerned about knobloch because he had like an encephalocele and he presented with nystagmus, which was very interesting. But anyways, that's why I remember hearing about that particular one. But anyway, yeah.
What was wrong with his retina?
Oh shoot.
It's okay. I'm just curious. I've never seen anybody with no block syndrome, so that's why I asked.
I think he had a detachment. I think because I remember we were going to do an EUA or a procedure, but I'm pretty sure that was part of it.
Okay, yeah. Great. Awesome. All right, so I sorted these into two groups, coats-like and fever-like. So with fever-like, we talked about the osteoporosis glioma. I would say like that's the more common thing. Mm-hmm. There's also Norrie syndrome, which is kind of like fever, but it can be really bad. Like they can be born with bilateral retinal detachments. And then there's 3 other diseases, 2 of which are not in the book, I don't think. Cutis marmorata telangiectatica, if I spelled that right, disc keratosis congenita. Both of these affect the skin, as you can tell by the disc keratosis and the cutis. And then the third thing, incontinentia pigmenti, is in the book, mm-hmm. and it also affects the skin.
Yes.
So tell me what you remember about incontinentia pigmenti.
So it can, it's like peripheral non-perfusion. It can look like ROP, right? And then
I think, things, can look like, ROP or fever, and, all these things can look similar. What about the inheritance of incontinentia pigmenti? Is there something unique that we haven't?
Oh, is it X-linked?
It is X-linked. Is it X-linked recessive in that it only happens to boys? Or
is it X-linked dominant?
Yes, very good. So it's X-linked dominant. So there are very, very few diseases that are X-linked dominant. So it's really unique in that way, in that, if a boy gets it, it'll be lethal. Mm-hmm. Whereas if a girl has it, the other X, normal X, can help compensate, and, it won't be lethal. So therefore, only girls have incontinentia pigmenti, and it's X dominant. Hmm. So excellent. So let's talk about the systemic findings, and then most of these are recessive, except, we forgot to talk about the fact that Norrie is another X-linked, so we got to remember the inheritance of that. It's X-linked recessive. Most fever is autosomal dominant, but these 2 diseases are recessive, and weirdly, the osteoporosis glioma can be either. No one's going to ask you that. Okay, so with coats-like diseases, there can be when someone has Coats syndrome, most of the time there's nothing wrong with the rest of their body, and it's only in one eye. With these 2 Coats-like things, the Coats is usually bilateral, and they have other things wrong with their body. So in Coats plus, it's a neurodegeneration type of thing. Just like when we went back to the, all those lysosomal storage disorders, they can have a really bad course where they die, in childhood. And then with facioscapulohumeral dystrophy, they have muscle weakness. And then, so for Norrie disease, they can, how did I do that? Okay. They can have seizures, cognitive dysfunction, and renal problems. And then, as we talked about, for all these 3 diseases, they have some sort of characteristic rashes that look really strange. You can Google them. That are, when they're newborn, and they might go away, later on. The incontinentia pigmenti folks have issues with their teeth, as well as seizures, and then they can have cognitive problems. So whenever you see someone, that looks like they could have fever, it's good, and they're a girl, it's good to ask about a newborn rash that was weird, problems with their teeth, and then these other things if you see them in the clinic with Dr. Hartnett. All right, so we covered all these phenotypes, and we just have the other category. Icardi, Jalili, I don't know how to pronounce that, Bietti, and Alport. So can you remember anything about any of these? It's okay if you can't. These are.
Yeah, it's like a crystalline, right?
Yes,
Retinopathy.
exactly.
And
Excellent.
it can also have corneal crystals as well.
Yes, very good. Excellent.
And then
Great.
Alport, is that, oh gosh, is that hearing problems?
Yes. Wow, you're doing so great.
Oh, yay!
So in Alport, they can have hearing problems. There's another organ that can be affected,
Is
which
it
is the
kidney?
kidney. Yeah, very good.
Oh my gosh,
Excellent.
I was like, for Alport, I was like, oh, it's either kidney or ear. I don't know why those are the two
Yeah,
that come. I
it's
least
for
I'm
both.
really good at multiple choice tests because I don't know why I just like, but then I'm not really good at like recall because I'm just like,
Right. Yeah. Definitely recognition is easier, much easier than recall, but great job there with the Alport syndrome. And
and I don't
then,
know any of the first two actually, or I don't
yeah,
recall.
yeah. So in Aicardi syndrome, they have these like characteristic lacunae, which is like, that's weird. Like, what's a retinal lacunae? Oh, darn it. But they're kind of like staphylomas, like, but there's a lot of them. They're like yellow and they're pooched out. And they also have agenesis of the corpus callosum.
Hmm.
For Jalili, they have bad teeth and colobomas as well as an RP type of thing. And you got Vietti. Oh, Alport syndrome, we didn't talk about their typical eye findings. The thing that most commonly comes up is the posterior lenticonus.
Oh, interesting.
But they also have like thinning of the temporal, just the temporal macula, like on OCT, you can see it's thinner there. And then they also can get a pigmentary retinopathy. Okay, that's all I have. Thank you so much for going through this. This was
Yeah.
really